and request for annotation. And if you have any questions, you can type in the chat box. These are certain disclaimers. And the upcoming talks are on 1st August, 7 p.m. And it is on transfusion testing by Dr. Rajesh Sawansa, consultant, transfusion medicine and histocompatibility and immunogenetics, Kopila Band Gurubhai, Ambani Hospital, Mumbai. And the next talk is on 6th August, 7 p.m. It's on basic statistics for medical students by Dr. Priya Ranganathan, professor anesthesiology, Tata Memorial Hospital, Mumbai. So I request Dr. Aaron ma'am to start the talk. Thank you.
Thank you to all the organizers for giving me the opportunity again to really give you this kind of introductory lecture on renal cell carcinomas. I understand most people in the audience are folks who are just getting into the subspecialty of pathology. And so I try to keep this kind of simple. And of course, renal cell carcinomas are a really complex heterogeneous group of tumors. So we just kind of get to the basic approach to the diagnosis of RCC and its subtypes. So I have no disclosures for this presentation. And when we talk about renal tumors, we have to remember that most of the tumors that arise in the kidney are epithelial tumors. You, of course, can get other things like sarcomas, like in any other organ system, but majority of the tumors are renal epithelial tumors. And the majority of the tumors that you will encounter in your surgical pathology practice are tumors that have been excised because they are malignant. And so the majority of these tumors in surgical specimens are malignant. Rarely you come across tumors which are benign. And the most common benign tumor of the kidney in autopsy series are papillary adenomas. But most commonly, the tumor which is benign that you will encounter in your surgical practice is oncocytoma. Now, when we talk about renal tumors, which are epithelial or epithelioid in nature, arising in the kidney, these are some of the differential diagnoses that need to be entertained of renal cell carcinoma. This includes urothelial carcinoma, which of course arises from the urothelium of the renal pelvis or the calyces, epithelioid angiomyolipoma, which is not an epithelial tumor at all, but can have epithelial-like cells, and hence the term epithelioid, and then of course metastases. Now, metastases to the kidney are extremely rare, and in a patient who has a diagnosis, let's say, of lung cancer, the presence of a synchronous tumor in the kidney is way more common than actually finding metastatic tumor of the lung in the kidney. So extremely rare, but something that needs to be kept in mind. Now, oftentimes when I talk to a first-year pathologist who comes, first-year resident who comes to sign out in our service, and we have a kidney tumor, the diagnosis they come forth is, oh, yeah, this is a renal cell carcinoma, and I always kind of stop them there because renal cell carcinoma is just an umbrella term, right? Because it covers a heterogeneous group of malignant tumors that arise from the tubular epithelial cells. So you can never have a diagnosis of renal cell carcinoma. There should be something that comes before that, which basically tells you what kind of renal cell carcinoma it is, because these are all very different biologically. They are unique because they have distinct histological appearance, they have distinct immunohistochemical profile, molecular signatures, and some of these tumors have very characteristic clinical scenarios in which these tumors develop. Now, with respect to epidemiology, these tumors form about 2% of cancers globally and about 2% of cancer deaths. So not that common with respect to mortality. In men, this is the 7th most common cancer, and it's the 10th most common cancer in women. This tumor continues to be more common in the higher income countries, mostly in North America and Europe. But the incidence of these tumors is rising globally. So you will also come across these tumors in your practice around the world. With respect to etiology, just a few things. We see these tumors more common in obese individuals, people, especially if you gain weight after or at the age of 50 years, if your BMI is very high, there is a higher chance of developing these tumors. Again, smoking, renal cell carcinoma is more common in individuals who are smokers than those who have never smoked. They're also associated with hypertension, and also, the treatment of hypertension, certain diuretics which are associated with acute kidney injury may also kind of contribute to the development of these tumors. You all are probably familiar with the fact that acquired cystic disease is increases the risk for the development of cancers. They're 100 times more likely than general population to develop RCC. So that's a very strong correlation there. And then occupational exposure to certain substances like trichloroethylene has been associated with higher risk for KSLRCC. And of course, there are a host of different kind of mutations and genetic susceptibilities to these various genes that are listed here, which are associated with the development of renal cell carcinomas. Now, renal cell carcinoma classification has really evolved over time, and as you can see, from 1970 to present day, the number of tumors has not only expanded from 2 tumors to 21 different subtypes now that we know of, but there has also been a change in nomenclature. There has also been more advancement on the classification of these tumors based on their genetic or molecular characteristics. Having said that, one has to be very careful because molecularly defined tumors can have a very broad morphological spectrum, and therefore this genotype-phenotype correlation is not always unequivocal in renal cell carcinomas. What I mean to say is that if there's a particular kind of growth pattern, you cannot say that, oh, because this growth pattern is there, this is a particular kind of genetically associated or molecularly associated renal cell carcinoma, because they now we know have a very heterogeneous kind of morphological presentation. Anyway, having said that, I think it's quite understandable that there has been this shift of classification based just on histology, immunohistology, and now we're going towards that phase where these tumors are being classified based on their molecular profile. We haven't reached the stage of what people do in hematology, but we are kind of slowly inching there, and therefore these classifications kind of become certainly challenging. And you can see here, this is the current, it's a table showing the current classification of renal cell carcinomas, and see there is this big group here of molecularly defined renal cell carcinomas, and you have quite a few tumors that have been listed in this particular category. And you can look at the morphology, you can do some immunohistochemical stains, but more often than not, you may have to do molecular testing to actually come to these diagnoses. Now, in addition to these almost 21 different subtypes of renal carcinomas, there are certain tumors which are not included currently in the WHO classification, but they're emerging tumors. These are the ones that are listed here to your left, and you can see where they are present in the current WHO classification. For example, papillary renal neoplasm with reverse polarity, or PRNRP, is not a distinct category right now. It is still included in the category of papillary renal cell carcinoma, despite the fact that they have very characteristic mutational status. And you can see many of these tumors that are listed here have characteristic you can say molecular alterations that are seen in association with these tumors. So unfortunately, the list is very long, and it can be exhausting for a trainee to really kind of familiarize themselves with these different subtypes. But I just want to reassure you that most of the tumors that you will encounter in your practice will fall into these major categories, and KSLRCC still remains the most common subtype of renal cell carcinoma. Now, why do we subclassify RCCs? Well, just like in any other tumor arising in any other organ system, it is important because of prognostic information that we get from subclassifying the tumors, which then informs the treatment and management of these different renal cell carcinoma subtypes. So let's briefly look at it. So we have tumors which are benign. So if you identify something as oncocytoma and the tumor is out, what we're telling the patient is you don't have to worry about this tumor recurring or metastasizing. So that's important. We also know that there are certain tumors which are listed here, which are indolent. That means over a long period of time, we have been observing these tumors and they hardly, if ever, metastasize. So these are basically you're telling them that, again, you're telling the patient that they have very good prognosis. So with respect to the more common tumors, clear cell RCC is got a better prognosis compared to papillary RCC, and chromophobe RCC has the best compared to these two. And then tumors like collecting carcinomas and medullary carcinomas have a much more graver prognosis. So when you give that diagnosis to the patient, we are really kind of telling them that their lifespan can be really reduced because of the presence of these tumors. Now, the treatment of clear cell RCCs across the board is surgical excision, whether it's partial nephrectomy or radical nephrectomy. However, once these tumors metastasize or are they advanced because there's local extension or they've spread, then you have to treat them with systemic targeted therapies, and there are various different types of therapies that have been recommended for these different tumor subtypes which are listed here. And there is also some role of immune checkpoint inhibitors, especially in sarcomatoid renal cell carcinomas. Now, for these tumors, for the diagnosis, pathological diagnosis of these tumors, it's very important to have a systematic approach. And this actually holds true for any tumor, right? You want to evaluate it very carefully during Gross exam at the grossing table. So the prosectors who are handling the specimens are the ones who are really kind of contributing a lot to the diagnosis and staging of these tumors. So the gross evaluation is extremely important. Then once the slides are ready, of course, we look at these under H&D and do a histological evaluation, come up with a differential diagnosis, then probably do some immunostains if needed. And then if required, we may even do molecular testing for developing the molecular profile. And all these we do understanding what the clinical findings are in this patient. So everything is done. There has to be a holistic approach for the diagnosis of these tumors. Now, I cannot re-emphasize the importance of gross evaluation. Extremely important. We have to know the location of the tumor, the size of the tumor, whether it's multifocal, unifocal, what is the color of the tumor, whether it's circumscribed or encapsulated or infiltrating. Does it have a cystic component? Is it predominantly cystic or entirely cystic, for example? Necrosis is another thing that we need to really look for because it is an independent prognostic parameter in clear cell RCC, so we really need to document that. And of course, we look at certain special characteristics of gross examination, for example, the presence of a central stellate scar, which may kind of help us at least develop a differential diagnosis. So let's talk about location, cortical versus medullary. Many of these tumors are cortical, some tumors are medullary, like the collecting carcinomas. The tumors can be exophytic or endophytic. That's important when we are kind of evaluating them for staging. Again, we have to look at these tumors carefully. If they're exophytic, to see if they're going into the perinephric fat. If they are kind of endophytic, then you have to see whether they're extending into the renal sinus or the renal vein or the pelvic leachial system. So all this is important when you're looking at the tumor at table. So here is some kind of cartoon that I made. You can see here to your left, you have this tumor which has a nice kind of smooth interface with the perinephric fat here. This is an exophytic tumor which is protruding in the fat. Here's another tumor which is more central in location, but it has again got a very smooth interface with the renal sinus fat. And then you have tumors like this where the interface is kind of irregular. And then you have these discrete nodules further out in the perinephric fat. Or here the central tumor again, you can see it's kind of irregular, and then you have these kind of circumscribed nodules that you see in the renal sinus fat. When you see this kind of nodules, it almost invariably represents tumor present within tributaries of the renal vein. So that is very important to document. And if you take sections from there, you will see that this is all examples of spread of the tumor beyond the kidney. So these are all examples of PT3A tumors that have gone beyond the kidney. Here's another example. When you have a tumor in the superior port of the kidney, it may directly extend into the adrenal gland, which is shown up there, and that may be then indicative of extension directly into the adrenal gland. And then essentially, I'm just trying to document or show you how we have to see if the tumor is encroaching upon the pelvic leachial system or infiltrating it. So you have to take sections from all this to document extension. Now, here's an example where there's tumor, but this tumor is distinct from the tumor that you see in the adrenal gland. That's important because this will represent metastases and not direct extension. So all these things are important to document when you're looking at a tumor. Here's an example of a tumor which is extending into the renal vein, and that can happen. And then, of course, you'll need to also look at the note and see if the tumor is going beyond the renal vein into the IVC or not. And then sometimes you'll also get sections or segments of the IVC along with the main specimen, and then you want to kind of take sections from there to see if they are infiltrating the wall of the IVC or the renal vein.
Sorry to interrupt, ma'am. Would you please use the laser pointer, the big pointer? The audience wants to. Yes, ma'am.
Sometimes it just disappearing. I was trying to, it just disappears at times. But is it better now? Can you see it?
Yes, ma'am. I can see the arrow. Yes, ma'am.
Yeah. Okay. Sorry about that. Is there something else that I can use?
There is one called the laser.
Okay, the laser pointer. Is that something that you can see?
The previous was better, ma'am. The laser one is better because it comes as a round dot kind of a thing.
Okay, laser pointer.
I suppose. Yes.
Is that better? Okay,
Yes,
I apologize. So thank you for bringing it to my attention. And okay, so awesome. So let's go on to the size. So I hope you guys could see and really the previous slides was just to try to show you how important it is to document the relationship of the tumor to the various adjacent organs or the perinephric fat, renal sinus, and also with the collecting system. Okay, so let's go on to the size. Size, of course, we have to look at the 3 dimensions of the tumor, and the largest measurement determines the stage of these tumors in organ confined tumors. So accurate measurements are essential. I keep telling all my trainees that make sure, if especially the tumor is confined to the then you have to know the cutoffs. Those are 4 centimeters, 7 and 10 centimeters, because that will really change the stage of these tumors. Now let's go to color. Now, kidney tumors, unlike any other tumors in the genitourinary tract, the gross description is extremely important and color is important. So here's a tumor which has this very characteristic, what we call mahogany brown appearance, circumscribed with this kind of central scar. You can here. Here's another tumor with a similar kind of appearance, more darker than the surrounding renal parenchyma. And here is another tumor which is again circumscribed, but it is kind of paler than the normal renal parenchyma. Another example of the same, paler than the adjacent renal parenchyma, but not quite yellow in appearance. Here is another tumor which is very, very yellow, or we can call it golden yellow in color. Here is a tumor which has a very heterogeneous kind of appearance with yellow areas, areas of hemorrhage. And here is a yellow tumor which has these large areas of gray-white discoloration, which appears much more firmer than the surrounding tumor. So these are important because the brown mahogany color tumor is an oncocytoma. Tumors which look paler than the normal renal parenchyma are usually chromophobe RCCs. And clear cell RCC, as you know, textbook appearance is that golden yellow color, but they can also be very heterogeneous in appearance, as you can see in this large tumor, where you can see a lot of hemorrhage within this tumor. So they can have a very variegated appearance too. And this is an example of a clear cell RCC with sarcomatoid differentiation. Extremely important when you see these gray-white areas within a renal tumor to take sections from here to identify the presence of sarcomatoid change within the tumor, and that of course changes the grade of the tumor. The next thing you want to look at, other than the color, is the circumscription, right? Is this a well-circumscribed tumor, as you can see here, or is it a tumor which has got a very irregular interface with the surrounding renal parenchyma? Or here is a tumor which appears kind of necrotic, but you can see it has a very well-defined capsule. So these terms are important. Circumscription, non-circumscribed, or tumor which has got a very well-defined capsule, so it's encapsulated, because this is the appearances of oncocytomas are circumscribed, but they do not have papillary RCCs usually are circumscribed and have a very well-defined capsule. Now, cystic change is something which again needs to be documented. Here is a tumor which has cystic components. Most of them, look dark here because they have blood within them. But then it has also these solid areas. So it's not completely cystic. It's a mixed solid and tumor. Here you have a tumor which is completely cystic, no solid areas, and has this kind of bubble wrap kind of appearance. And then here's another tumor which is predominantly cystic without any identifiable solid areas. Now, these are examples of clear cell RCC with cystic change, where you have that solid cystic kind of thing. Tubular cystic renal cell carcinoma, you can't make the diagnosis unless you exclude the presence of any solid component. And so also multilocular cystic renal neoplasm of low malignant potential, which can mimic a clear cell RCC with extensive cystic change. And the growth is extremely important because in this tumor, you should not see any expansile solid foci within the cystic components. If you see that, you can't make a diagnosis of multilocular cystic renal neoplasm of low malignant potential. So gross evaluation is extremely important. Now, with respect to scarring and hyalinization, it's not very specific, but you kind of areas. For example, in this oncocytoma, you can see kind of central scarring. This is a pale tumor, so this is actually a chromophobe RCC. Sometimes you can see central scarring even in this chromophobe RCC, but usually for a multiple choice question, if you have oncocytoma and chromophobe, you want to pick oncocytoma as the tumor which shows a central stellate scar, which is also seen on radiology and CT images. Now, clear cell RCCs can this kind of myxoid degenerative changes in the center of the tumor usually, and you will see this kind of hyalinization of the tumor under the histological on H&E images. So oncocytoma, chromophobe RCC, and clear cell RCC. So, a good gross description is really half the work done. It makes our life so much easier if a good gross description has been performed and, good sections have been taken to document not only the different areas grossly within a renal cell carcinoma, but also to document the stage of the tumor. So, if I have a good gross tumor which has been grossed in properly, it literally takes very little time for us to sign out these cases. Now, clinical features, as I mentioned to you, can be important. For example, if you have a history of end-stage renal disease in a patient and the patient has a history of dialysis, and then if everything fits and you're thinking of ACD-RCC, then it is most likely the diagnosis, right? If you have early onset of renal cell carcinoma patient less than 40 years, right, you might start suspecting translocation-associated RCC. But just a caveat, remember that you can have translocation-associated RCCs also presenting at a later stage. So that should not really kind of stop you from making that diagnosis if everything else fits. And then, of course, syndromic renal cell carcinomas are usually early onset, right? They can also be multifocal. And then, there are certain very characteristic clinical scenarios like the presence of sickle cell hemoglobinopathy and its association with medullary carcinoma and alveolar renal cell carcinomas. So let's come to what we do every day, and that's histologic evaluation. So after looking at the gross, having a good gross description, we look at the histology. And for the diagnosis, I basically really lay a lot of stress on this portion of the tumor assessment, which is the architecture of the tumor, the cytology of the tumor, and then look at the background stroma. And remember, IHC is always an ancillary tool. So you have to develop a good histological differential diagnosis and then apply appropriate immunostains to kind of come to a diagnosis. And then, of course, molecular profiling is required in certain instances. So don't throw a lot of immunostains and hope some of it will stick to the wall and make a diagnosis. That's not the way to approach any tumor in the body. You have to have a good working histological diagnosis. So when we talk about histological evaluation, these are the three components, right? You look at the architecture, then the cytology, and the background. So architecture tumors can be nested. You'll hear terms like sinusoidal pattern, alveolar growth. Then you can have tumors which are papillary, cystic, infiltrative, etc. Then you look at the cytology. Are these cells predominantly clear? Is there a mixed kind of appearance with both clear and pink cells? And because there are lots of tumors, especially some of the newer tumors, which are predominantly pink. Then you look at the cytological characteristics of these pink cells. Is the cytoplasm granular? Is it flocculent? Does it have well-defined cytoplasmic membranes? And then there are certain special features that are associated with certain tumors. Is there cytoplasmic stippling? What is the association of the nuclei with respect to the basement membrane? What is that? Is the nuclear alignment of the tumor cells? Presence of viral inclusion-like nuclei? These are all certain special characteristics that we know are associated with certain tumors. So you want to look at these features. And then, of course, last but not the least, look at the background. Is it edematous? Is it mucinous? Is there a lot of smooth muscle stroma? Are there calcium oxalate crystals present? Are there Sonoma bodies? Is it very inflamed? All these things put together help us arrive at a diagnosis. Now let's look quickly at some architectural patterns. So here, these are all of tumors with a nested kind of pattern. So here you have these nests which are much more compact, and you can see this filigree-like a framework of small sinusoidal capillaries. So this is more like a sinusoidal pattern, and here you have these expanded nests again, which are partially circumscribed by a capillary network. Then you have here nests which have this kind of more tubular kind of architecture with the nuclei and a more peripherally aligned. And again, here is an expanded nest with cells having large amount of cytoplasm. So these are all examples of tumors with a nested pattern, and you can see there are multiple tumors that can have a nested kind of appearance. Here are examples of tumors which are papillary, right? Here's one tumor which has papillae with a lot of macrophages within the core. Another papillary tumor with mostly pink cytoplasm lining it. Again, another tumor which has this tubular and papillary appearance, and the papillae have this very fine kind of hierarchical branching. And again, another papillary tumor which has pink cytoplasm and nuclei away from the basement membrane. More kind of peripherally placed nuclei. So these are all different kinds of tumors, and this is an example of papillary renal neoplasm of reverse polarity, PRNRP for short, and then this is an example of a clear cell papillary renal cell tumor. Again, these are examples of cystic tumors. This is one where you have multiple size cysts here on your left upper panel. I don't know where this is gone now. Okay, can you see my pointer, the laser pointer? Okay, so here you have multiple cysts, but you have this kind of hyalinized stroma, no solid areas, cysts, but you have some solid areas here. Another example of just cysts without any solid areas, cysts lined by pink. So these are all tumors with a cystic architecture, but these are all different kinds of tumors. So that's important to know what are all the differential diagnoses. Now here's an example of tumors which have this kind of infiltrative growth. So here you have these kind of angulated gland-like structures or tubules which are infiltrating into this stroma, which is kind of more sclerotic, right, hyalinized kind of stroma. Here are cells which have got very, very high-grade cytologic features, infiltrative, eccentric nuclei with some sickling in the background of the RBCs. Again, infiltrative growth pattern, more like glandular with that stroma, some kind of papillary architecture, but again, it's all infiltrative, right? So these are examples of the lower two FH renal cell carcinomas, collecting duct carcinoma to your left and alk rearranged renal cell carcinoma, which, as I mentioned to you, can be seen in a setting of hemoglobinopathy. So then we look again at the these tumors, tubular or glandular, right? Here, again, tubular kind of architecture, tubular, and you can see there are so many different tumors which can have this tubular or glandular kind of appearance. And again, now we're looking at the background, and you can see here the presence of kind of a mucinous kind of background here. Tumor is tubular and has a mucinous background. Here you can see the presence of Sonoma bodies. Here you can see some crystals that you can identify here. And this is again presence of kind of smooth muscle stroma in the background. And these are all the different kinds of tumors. So the evaluation of all these components are important. Now let's now briefly talk about the cytology of the tumors. Of tumors with clear cell morphology, and you can see various different tumors, but they have also different kind of architectural patterns, right? So that helps. So that's clear cell RCC, chromophobe, translocation, clear cell papillary renal cell tumor. And then, of course, the bane of our existence as geopathologists are tumors with pink cells. So here you have different types of tumors with pink cells, and this is an example of a clear cell RCC, which can sometimes be predominantly eosinophilic or granular. This is an example of an SCRCC, oncocytoma, and then, of course, chromophobe RCCs can have predominantly pink cells, in which case we call them eosinophilic chromophobe RCC. So it's very important. So once you look at whether if it's a pink cell, for example, you want to kind of do a little bit more of a deep dive into the morphology of these cells, or maybe look at the cytologic characteristics a little more closely, and you'll see that in chromophobe RCC, the clearing that you see is the pink cells that you see have that kind of flocculent cytoplasm, or you can call it like, just they're not very big granules or not densely granular. Whereas in the oncocytoma, the pink cytoplasm is characterized by these really kind of individually you can identify the granules. So there's very nice eosinophilic granular cytoplasm. It doesn't have that clearing that is associated with chromophobe renal cell carcinoma. And then, of course, this is just interesting to see. I don't know if you can see, where did my laser pointer go? Okay. Can you guys see this? Here you can see this little kind of stippling, which can sometimes be basophilic in appearance. Sometimes it can look a little pinker, as in this instance. Almost looks like leishmania bodies with this clearing around them. This is the cytoplasmic stippling that we see in the RCC, or eosinophilic solid and cystic carcinoma. And then this is the typical SEV-like intracytoplasmic luminas that you see in the ACD, that is acquired cystic disease renal cell carcinoma. An example of the typical piano key appearance, where the nuclei are away from the basement membrane. This is the characteristic morphological feature that is associated with clear cell papillary renal cell tumor. And then here, just to show you this really prominent viral inclusion-like nuclei. Again, I'm trying to get the pointer, but you can see it here in the center. This big, almost like CMV inclusions. They look like big eosinophilic nuclei that you see in FH-deficient renal cell carcinomas. Now, in the next few minutes, I'll try to quickly run through the common tumors that you see in the kidney. Clear cell RCC, yellow, golden yellow, can be variegated, characteristic morphological appearance with clear cells. You can have eosinophilic areas, but if you see these kind of areas in a tumor, then you know that you're looking at a clear cell RCC, however heterogeneous other areas may look like, because it's got that sinusoidal architectural pattern. Now, as I mentioned, you can get sarcomedoid features. So if you take sections from that solid white areas, you will see this growth pattern where you have tumor cells which are spindled in appearance, growing in almost fascicles. That's sarcomedoid tumor. Sometimes you can have tumors within clear cell RCC where the nuclei are eccentric and you have this inclusion like cytoplasm, and those are the rhabdoid areas within the tumor. This morphology, I just wanted to imprint it in your mind, is the typical morphology of clear cell RCC. In any tumor which shows this, I don't care how other areas look like, but then this is definitely a case of clear cell RCC. Here, again, this is just to show you necrosis, which has to be differentiated from infarction. In necrosis, you will see the pycnotic nuclear debris, which you don't see in infarction. This is important because it's an independent prognostic parameter for clear cell RCC. And this is to show you some of the heterogeneous features that you can see with clear cell RCC. Here, it almost looks more tubular. And this is just to show you how sometimes it can also show you this vague piano key-like appearance, which you see with clear cell papillary renal cell tumor. So clear cell RCC is a great mimicker. It can really look like different tumors in different areas. Here you see it's so highly nice that the areas of the tumor that you see here almost look like they're fat cells, right? So for the uninitiated, this may look like something benign. It doesn't look like a clear cell RCC at all. Here is an example where I can see the cells are more pink, right? And you can see these kind of inclusions within the cytoplasm, which are pink globules that can sometimes be seen in these tumors. So what I tell my trainees is that clear cell RCC has this very characteristic morphological appearance, right? But you want to do immunostains if the morphology does not add up, right? And then the IHC panel that you're going to choose will depend on the morphological differential diagnosis that you're entertaining, right? You don't want to do 20 immunostains. That's going to really confuse the heck out of you. So just use those immunostains which will be appropriate for the morphological differential diagnosis that you're entertaining. So the stains that I use usually is CA9, and CD10 I use only when I'm thinking about certain differential diagnosis, like distinguishing clear cell RCCs from clear cell papillary renal cell tumor, because clear cell papillary renal cell tumor is usually negative for CD10. So I don't use CD10 to make the diagnosis of clear cell RCC, which I see happen in the community practices around the world. So it does happen. So CA9 is a good stain. Now, here's a case of a chromophobe RCC. Chromophobe RCCs are characterized by clear to pink cytoplasm, and they have this typical coilocytotic kind of nuclei, right? Very well defined cytoplasmic membranes, almost like plant cell-like. So that's very characteristic of chromophobe RCC. Here's another example where the nuclear features are not very well developed, but you can see there are these perinuclear halos, because here the cytoplasm is a little bit more pink. And sometimes you can see areas of calcification. There's also an example of a chromophobe RCC. You can see the nuclear features. You can see binucleation very often in these tumors. You can get large areas of hyalinization sometimes, especially in the center. And this is an example chromophobe RCC, which is mostly pink, and so you don't see that pale staining appearance of the cytoplasm. But what you see is the perinuclear halos. You start the nuclear membrane irregularities still remain, and the cytoplasmic, you can see the membrane prominence, right? So this is an example of chromophobe RCC. So when I'm thinking of, is it a chromophobe? Is it a cancer? You want to do CD117, which is diffusely positive in these tumors, and CK7 is very helpful in this differential diagnosis that we are entertaining, right? Now, here's another common pink tumor, which is an oncocytoma. It's characterized by this nested appearance, edematous stroma, and this very characteristic granular cytoplasm. And the most important thing is the nuclei. The nuclei look really kind of uniform across these tumors. They're round. They don't show nuclear membrane irregularity. And here's a good example to show you the roundness of these nuclei, right? And that really helps make the differential to distinguish these oncocytomas from eosinophilic chromophobe RCC. So here's just a small table to show you the difference between these tumors. So both oncocytoma and chromophobe RCCs, especially the eosinophilic chromophobe RCCs, can have pink cytoplasm, but there's a difference in the characteristic features of the cytoplasm as is listed here. Cytoplasmic membranes, again, indistinct in oncocytoma, very prominent in chromophobe RCCs, and the nuclei. That is really, really important to distinguish oncocytoma from chromophobe. Now, the stains, they're positive both for CD117. They are usually negative for CK7 in oncocytoma, or you may see rare scattered CK7 positive cells. Chromophobe RCCs are diffusely positive for CK7. So CK7 is a good stain to distinguish the two of them. And of course, one important morphological parameter that I want to mention is mitosis. Mitosis, if you see in a pink tumor, which where you're entertaining the differential diagnosis, oncocytoma and chromophobe RCC. If you see prominent mitosis, then it's not an oncocytoma. Okay, we don't want to call it oncocytoma with mitotic activity. Now, this is an example of papillary RCCs. Again, a very broad morphological differential diagnosis. You can have lots of different morphology in papillary renal cell carcinoma. You can have cells like this, which are more cuboidal in appearance with scant cytoplasm, almost kind of amphiphilic kind of cytoplasm with hyalinized kind of stroma, or you can have macrophages within them, or you can have tumors like this, which are very different, higher grade pink tumors. They all these are called type 2 papillary RCCs, but currently we don't divide papillary renal cell carcinomas into type 1 and type 2. They're all just under one uniform morphological term of papillary renal cell carcinoma. One stain that is really good in the differential diagnosis of this tumor is racemase, which is positive in papillary renal cell carcinoma. CK7 is diffusely positive in the so-called type 1 papillary RCCs, but maybe very focal or patchy in the so-called type 2 papillary RCCs. So that can vary a lot. Now, here's an example of a clear cell papillary renal cell tumor, which has this kind of tubular architecture, can have also small papillae within them, and they have clear cytoplasm and the piano key-like appearance, which you can see here, nuclei away from the basement membrane. And with respect to immunostains, these are diffusely positive for CK7, something that you don't see in clear cell RCC. They're also positive for high molecular weight cytokeratin. Racemase is negative, and CA9 is positive, which is of course positive also in clear cell RCC. But you see that the CA9 pattern is a little different in clear cell papillary renal tumor. It is not circumferential membranous. It is more cup-like, which is basolateral staining of the cells, and that helps distinguish clear cell papillary renal tumors from clear cell RCC. They can also be positive for GATA3, and CD10, as I mentioned to you, is usually negative in these tumors. Again, helpful to differentiate between clear cell RCC. So this is just showing GATA3 at higher power, nuclear positivity, helpful. So as I mentioned to you, IHC can be important, and there are certain specific roles, right, for distinguishing, for example, renal origin of a tumor in a metastatic site. You want to use IHCs which are specific for a renal origin. It is not required for the routine diagnosis of most of the common subtypes that I've highlighted to you in the presentation, and it should be reserved for scenarios where the morphological features are overlapping or suggestive of a less common subtype. So I don't routinely do IHC for the more common subtypes of RCC. Now, when you're evaluating for primary origin, use PAX8. Don't use RCC markers, CD10. These are not specific markers. PAX8 is the best stain to be used. CA9 membranous staining, as I mentioned to you, is what you see with clear cell RCC. Cup-like positivity is seen in clear cell papillary. This should be tumor, sorry for that mistake here. CK positivity can be seen in chromophobe RCC and oncocytoma, but if you want to differentiate these two, you want to use CK7, which is diffusely positive in chromophobe RCC. CK7 and racemase are positive usually in papillary renal cell carcinoma. So these are the important immunostains in these subtype. Here is a case of a clear cell RCC. This is a case of chromophobe RCC. This is a case of a clear cell papillary renal cell tumor. I'm just showing these images again and again so that it gets kind of imprinted in the minds of the viewers. And these are tumors with clear cytoplasm. So there's a whole host of immunostains that you can throw on this stain. But these are common tumors: clear cell RCC, chromophobe. Sometimes you get translocation associated RCCs which have clear cytoplasm and clear cell papillary renal cell tumor. Right? You want to throw these stains, and CA9, CK7 can be very helpful. I don't want to go through the whole list because again, everything depends. What is your differential diagnosis? Now, pink tumors can also be clear cell RCC, oncocytoma, chromophobe RCC, and this is a different kind of stains that you can use for tumors with pink cytoplasm. But believe me, I don't use all these stains. I will use the stain depending upon the differential. But CA9 is very helpful because it'll help include or exclude clear cell RCC, right? And once you've done that, then you want to say, okay, that's not a clear cell RCC. Is it a chromophobe RCC? Do CD117, do CK7, and then of course, if it's an epithelial angiomyolipoma, for example, all this keratins will be negative, right? And it'll be positive for melanocytic markers like HMP45 or microthalamic transcription factor and cathepsin K. So knowing what your differential diagnosis is, you tailor your immunohistochemical panel Now, tumors which have tubular or tubular papillary, again, your differential diagnosis may be papillary RCC, clear cell papillary, metanephric adenoma, which is another benign kind of tumor, mucinous tubular and spindle cell tumor, and MITF, translocation associated tumor. And here are all the immunostains that can come handy in kind of distinguishing these tumors from the others. So again, common tumors first. So use those immunostains which may help differentiate separate out the more common tumors, and then you go stepwise and try to do other stains to build, confirm your diagnosis. Now, when we talk about tumors with high-grade infiltrating growth pattern, one tumor that should always be kept in mind is urothelial carcinoma. You want to distinguish urothelial carcinoma from a high-grade renal cell carcinoma because the treatment is very, very different, right? So then you want to kind of use certain stains, like for example, P63 is positive in carcinoma is negative in all these other tumors that are listed here, right, in the differential diagnosis. Again, it can be really helpful to exclude urothelial carcinoma because I think importance is the management of these patients. So just make sure to not forget a urothelial carcinoma in the differential diagnosis of a high-grade infiltrating cancer in the kidney. Now, briefly, I'm so sorry if I'm running through the slides, but there's a lot to present, and I just wanted to briefly talk about the WHO ISO grading system. So that is what we use to grade these tumors depending on the nuclear prominence. So if the tumor shows prominent nuclei at low magnification 10x, then it's a grade 3. If it does not show prominent nuclei even at a high power 40x, then it's grade 1, and then something in between is grade 2. Most of these tumors are grade 2, but some can be grade 1, and of course the high grade tumors are grade 3. And then of course, if you have sarcomatoid differentiation or rhabdoid differentiation, then it is a grade 4 tumor. And then you can have also tumors where you have these tumor giant cells, and when they are present, then you grade the tumor as grade 4. So grade heterogeneity is a feature of renal cell carcinomas, right? So you have to sample adequately, and you want to kind of, as I mentioned, look at the gross and kind of target areas where you think there could be sarcomatoid areas, and then if you see a higher grade areas we see in one high power field, that will determine the grade of the tumor, right? So that is important to notice in a tumor, and you want to kind of make sure that you're adequately grading it. Now, WHO ISO grading is not uniformly applicable to all the tumors. It is validated for these tumors listed here. It is not applicable for chromophobe RCC, so you don't want to grade chromophobe RCC because it is not applicable at all. And in certain tumors like these tumors listed here, they are characterized by prominent nuclei, but their behavior is kind of relatively less aggressive, right, compared to a clear cell RCC with a grade nuclei. So it can be potentially misleading in these tumors. So that's the importance of knowing where to put the grade. Now, tumor necrosis, again, as I mentioned to you, is an important prognostic meter in clear cell renal cell carcinoma. So please, when you identify tumor necrosis, do mention it in your report. Now, here is the staging of clear cell RCC. I have briefly gone over it in my initial presentation on gross evaluation, but just kind of bringing your attention to the fact that if you have a tumor that's limited to the kidney, then the size is important. And the cutoffs, right? Remember, 4 centimeters, 7 centimeters, 10 centimeters, right? Those are important cutoffs. Once the tumor has gone outside the kidney, the size really doesn't matter, right? But just when it's limited, remember that. And this all stuff I have already gone through, extrarenal extension, how you kind of look at it and evaluate it grossly, and to make sure you take extensive sections to document that. This is an example of a clear cell RCC growing into a muscle-containing branch of the renal vein. That's important, right? This is tumor involving the pelvic calyceal system. This is all PT38 tumors. Phew, that was quick. So let me just go through a few questions. So here's a case, CA9 staining in clear cell RCC is characterized by which of the following? 1, 2, 3, and 4. And the answer to this, of course, is circumferential membrane staining. That's something that you want to kind of always remember. Now, the following statement regarding clear cell papillary renal cell tumor is true. Does it show diffuse CK7 and Amicar immunoreactivity? Is it usually CD10 positive? Does it show circumferential membrane staining? Is it characterized by 3P loss, which is where the VHL gene is? Or is it characterized by an indolent clinical behavior? And the answer is the fifth one. It has a very indolent clinical behavior. And so that's why it's important to distinguish this tumor from clear cell renal cell carcinomas. The third question, papillary adenomas of the kidney have a size of less than or equal to 15 millimeters or 1.5 centimeters. They're encapsulated and therefore benign. They do not show trisomy 717 with loss of Y chromosome, are uncommon in end-stage renal disease, are usually medullary in location. And the answer to this question is have a size of less than 1.5 centimeters. So the second response is wrong because you can have papillary renal cell carcinomas which are encapsulated but they're malignant. Trisomy 7 and 17 with loss of Y chromosome is a molecular characteristic of papillary renal cell carcinomas, and papillary adenomas are considered to be putative precursor lesions of papillary RCC, and they show similar cytogenetic alterations as mentioned here. So this third sentence is also not true. They are very common in end-stage renal disease, as I mentioned to you. In an autopsy series, papillary adenomas are the most common benign tumor of the kidney, and these are cortical tumors. They're not renal medullary tumors. And that's all. And I'm quite proud of myself that I finished the presentation in an hour's time. So that's all I have for you. Let me see if I can stop sharing my screen. I don't know if I can do that. Maybe somebody else who's a host can do that for me, and I'm ready for questions if you have any.
Thank you, Madhumani. Thank you for the very, very useful presentation. And you can see the comments which are coming on screen.
Okay.
Are there any questions from the moderator?
Yes, sir. There is one question. How to identify peritumoral fat extension or crossed renal capsule when there is fibrosis or pseudo capsule around infiltration focus?
Excellent question. And this is something that we always, kind of struggle with sometimes. And what I do is if I see there is this kind of irregular infiltration, even if there's a pseudo capsule around it, that is important. And I look at how close it is. If it's like protruding and there's this irregular kind of a capsule around it with, at the level of the fat, then that helps. But sometimes it is difficult. And it helps sometimes to take multiple levels in these and to see if you can actually see individual microscopic, tumor infiltrate into the fat. But sometimes it is hard. And I'm not going to, because, for those people who don't know what we're talking about, when these tumors push into the fat or so-called infiltrate into the fat, they can produce pseudo capsules, which is basically fibrosis as a result the infiltration of the fat, and that is difficult to differentiate from the renal capsule. So that is difficult, but these are some of the pointers that I have, which I've shared with you, which may help in making this distinction.
Thank you, ma'am. The next question is, ma'am, metastatic RCC can present at various sites. Can you share uncommon sites you have come across? Can this
Oh, great. Yeah.
After a very long gap? Dedicate.
Yeah, mets can present at after multiple years. The patient may have a very, very remote history of renal cell carcinoma, and oftentimes, they may not even be elicited in the clinical chart, right? So that can happen. They can metastasize after 10 years, 20 years, and it can appear just out of the blue in some location. Of course, common side, well, I have seen metastasis. A drop metastasis of this renal cell carcinomas in the ureter. I have seen it in the urethra. So these are all kind of uncommon sites, and I'm saying these because I'm a genitourinary pathologist. In our practice, all the metastatic tumors, wherever they arise, they go to those subspecialist sites. Of course, you see in the brain, you see it in the skin, you can see it, in sites. I have seen them in other genitourinary sites, and they can occur anywhere in the body. So you have to have a very low threshold because if they usually look like they kind of recapitulate the morphology of a clear cell renal cell carcinoma. So keep a very low threshold in the differential diagnosis. Does that help?
Yes, ma'am. Of course, it helps. No more questions are appearing, ma'am. Yes, yes, ma'am. They are thanking you. There's one question. Does molecularly defined RCC show a really distinct morphological feature that is identifiable? And when do we need to suspect this entity? And how important is it to recognize these entities?
Excellent questions. And of course, I tried to kind of, I think I mentioned in my slides that there is a disconnect, right? We used to always think initially, for example, the first group of tumors molecularly defined that we identified by these translocation associated RCCs. And, the XP11 translocation was the thing that for a long time, really kind of captured our imagination. We said, oh yeah, if you have a tumor which is clear and abundant cytoplasm, then it is, XP11 translocation associated RCC. But over the years, we have seen that there's been expansion in the morphological, descriptions of these molecularly defined renal cell carcinomas. So yes, mixed patterns are important sometimes, which help identify some of the tumors. And really, the simple way of answering, and maybe it's a very unsatisfying answer that I might give you, is that you have to exclude, right, the more common tumors. And once you exclude them, then you have to say, okay, this is not fitting into a clear cell RCC, not fitting into a typical papillary RCC, and it has all these other features. So there is some correlation, but there is not an exact correlation, right? So we have to keep that in mind. Now, there are certain tumors, for example, SDH reals. Again, actually, I should withdraw that statement. We had a publication sometime back from Dr. Gill's group where, they really kind of expanded the SDH associated carcinoma morphological spectrum. So, it is very varied, right? And you have to have a low threshold in the right setting. Once you've done the stains to rule out the more common subtypes, then you start suspecting certain of these molecularly defined RCCs. Of course, there are certain characteristic morphological parameters. If you identify them, then you're in the, having the right differential, so you are suspecting that. And not always required molecular testing. We don't, I don't know what the practice in India is, but we don't always do molecular tests. But sometimes, yes, like for example, translocation associated renal cell carcinoma, I always do a FISH, just to make sure if it's TFE, and we don't have TFEB at our place, we have to send it out. But we do try to do it, but not required. For example, STH, right? If it is, there's a good stain that you can use, and if that works, if there's no staining with STHP, then kind of make the diagnosis. If things are equivocal, right, based on molecular and immunohistochemical, but you have a very strong suspicion that this could be a molecularly defined RCC, then go ahead and do the molecular test in these tumors. Does that help?
Yes, ma'am, it's helping.
Okay.
Ma'am, there are many questions regarding grossing. So one has asked, ma'am, sections from tumor during grossing. Now another doctor grossing video of RCC specimen.
Do you want to be my scribe when I do that? You can take the video with me. I'm happy to. Yeah, I'm not kidding. I think it'll be fantastic. That's one of the multiple things that I have planned. To take small video snippets. It will really help to have it to show you how to gross. But it's not really hard. Grossing tumors for the just knowing what the framework is within which you have to kind of gross these specimens to first to classify them. So, looking at all this, kind of talking about the color, the circumscription, presence of cystic change, all that stuff, and then things that help prognosticate the tumor. So, is there necrosis there? What is the stage, right? So those are the things that if you just take sections to document that, you really going to do a good job. So it would really help if somebody would present have a small video showing how to tumor. But then every tumor is different, right? So if I have a tumor which is 7 to or smaller than, it's a T2 kind of tumor by size, and it is very close to the sinus, I'm going to pay a lot of attention to see if the tumor has extended out, because there is statistics that show that if there's a tumor that's large, the 10 centimeter size, you have to exclude extension. So you want to take more sections, 2 or 3 sections, for example, from the renal sinus if it's more of an endophytic tumor, or 2 or 3 sections from a more exophytic large tumor to exclude microscopic extension into these perinephric fibrorenal sinus. Okay.
Another asks, which one has worst and best prognosis?
Amongst what? Sorry.
Most probably, ma'am, amongst RCCs.
Oh, well, that's a very, very difficult question to answer. But if you're talking about RCCs, right, then we are talking about tumors like I mentioned to you, compared to the common tumors, right? Something like chromophobe RCC may have a good prognosis compared to a clear cell RCC. Of course, if you're talking about something like a collecting duct carcinoma or a medullary renal cell carcinoma, then you're basically of the death sentence, right? These patients are going to do really poorly. So yeah, these are the tumors that you have to identify, because these are really bad actors. And if you identify these tumors, then you are really telling the patient that their prognosis is really poor.
Dr. Jigna is sharing that he or she has seen metastatic RCC in breast after 10 years of operated clear cell RCC.
Yeah, I'm glad you had the history of operated clear cell RCC. Many times you don't even have that, because 10 years a patient has had some, they don't even recall, like, oh, we had a clear, tumor, maybe. I mean, you have to sometimes probe really hard to even have a history of clear cell RCC or something, tumor, or even surgery in the site. Yeah.
He had metastasis in the tongue.
See?
Tongue metastasis.
Okay.
And they started
Wow.
like ASPS also.
Yeah,
The
yeah,
domestic pattern and granular cell tumor, and those come in the different shape.
Yeah. Absolutely. So they
I
can
have
occur anywhere.
just one discussion point. Do you find sometimes that CA9, we rely on CA9 a lot these days? Because clinically for the clinician, clear versus non-clear becomes the most important question.
Right.
But I'm telling you, by practice, sometimes CA9 becomes difficult to interpret, very focused. And but it is very nicely membranous and focal. But then there are eosinophilic areas which are not very strongly possible. CA9. What is your experience on CA9? Because we are so much relying on CA9 these days,
Yeah. So, but so let me tell you. So CA9,
especially in the
I use.
metastatic side.
Yeah. So in the metastatic side, I agree. It can be a little difficult because although most of the times they do kind of retain the morphology of clear cell RCC, with that sinusoidal packaged arrangement, it may not help. So what I do is, first thing I do a PAC and see it's a renal origin, right? And then if if it is in the metastatic side and you have not had any previous history like we're talking about, and it has any area that is clear and it's showing CA9 positivity, then it is likely to be a clear cell renal cell carcinoma. It's showing the diffuse membranous kind of staining. Absolutely right. When it becomes higher grade, and those are the ones where you have the more pink cytoplasm, it may not be that helpful. But if the morphology does not fit into the other pink tumors, right, then I'm not really concerned. So in my experience, CA9 does kind of work, but you are absolutely right, and that's a very valid point that you raised, where that in the pink area sometimes you may not be able to elicit that nice diffuse membranous positive. But I just go by, the morphology, and I just try to kind of see if it's fitting into any other kind of pink tumor, right? If it is not, then it's unlikely to be anything else. KSLRCCs are the more common tumors. They're the ones which will metastasize the way that we expect them to go into all these different sites. So it's likely the tumor that we are encountering in these locations.
Ma'am, you mentioned in the picture rheumatoid differentiation. The gross features, ma'am, is that the fish flesh appearance you're talking about?
Right. The fish flesh firm, pale areas that you see, almost gray white areas that you see in the tumor. That's where you want to focus your attention on, because those are the areas which look different from your normal clear cell yellow, hemorrhagic kind of variegated kind of appearance that you normally see in the other areas. Here it becomes more firm fish flesh. Absolutely.
And ma'am, how can we differentiate a papillary adenoma from a subcentric papillary RCC?
Centimeter.
Centric means ma'am less than 1 centimeter, because
Sub-centimetric.
yes, sir.
So if it is less than 1 centimeter and it is not showing high nuclear grade, right? And if it is not encapsulated, then that's a papillary adenoma. Okay, because size is important, of course, and the nuclear features are important.
One doctor is sharing that he or she has encountered a case that came with brain mets as first in presentation, brain metastasis as first presentation.
Wow, yeah, that can happen too. Because sometimes you can have very small renal carcinomas in the kidney, right? So you don't necessarily have to have a huge renal cell carcinoma for metastasis to be presenting itself. So it can happen, and rarely, we have anecdotal reports of these actually involuting KSLRCCs, just completely disappearing like you have with melanomas. But I don't know how in the recent history. I mean, these are all kind of very older kind of publications, but it is possible that can also happen, right? So you may not find a primary, and then it becomes very difficult. The differential diagnosis in the brain, hemangioblastoma, all that stuff comes into play, right? So you want to be cognizant of that.
I think even RCC, even for a grade 1, grade 2 tumor can metastasize. So they need not be very
Right.
precise and not be very high grade to metastasize. Although
Absolutely.
it's not very common, but they can.
Again, ma'am, some questions are popping up. So there is one question, ma'am. How can we say on morphology that it's a clear cell carcinoma if the cytoplasm is eosinophilic?
Good question. And again, so this opens up that whole discussion on pink tumors, right? So this is what I tell my trainees, right? You have a tumor which looks like a clear cell RCC and grows, is very variegated, it's got all these. You focus areas, you start taking sections from there, you will see areas which will have that typical sinusoidal architectural pattern, right? That is, I think, the hallmark of clear cell renal cell carcinoma, not the clearing of the cytoplasm necessarily. Having said that, there is that nuclear cytoplasmic asymptomy that you can sometimes see in these tumors, but that is very, very kind of important to kind of identify. So the architecture is important, and having said it is these pink areas which will show maybe more expandedness, will probably show areas which have more higher nuclear grade, right? In fact, that is a tip that I want to pass on, that when you're looking, when we talk about grade heterogeneity in a tumor, right, you want to identify the highest grade, and you go to the pink areas, that's where you see the higher grade tumors. The more clear areas will probably have the lower nuclear grade, but yes, the architectural pattern is, I think, the more important thing, the sinusoidal architectural pattern that you see. And any foci where you see that typical compact sinusoidal architectural pattern, that is enough to call it clear cell RCC, because you can see a lot of tumor heterogeneity, both in the architecture, the cytological features, etc. So look for these areas and sample adequately, and you'll find it if you look hard enough.
Ma'am, I had a question. Like there was a case, it was TCC, but the TCC had originated from the ureter. Now, to us came first the kidney. So the kidney was entirely TCC. It had involved the cortex and medulla and everything. So in such a case, how do we do the staging? Do we follow the ureter and the renal pelvis staging?
So it depends, right? So if you have two distinct tumors, then you have two different stages, right? So if there is now urothelial carcinomas are known for multifocality, right? So you want to look at, so if I understand correctly, if the kidney tumor was present, the tumor in the pelvic ileal system was resected out first, right? And so they must have done, did they do a nephroureterectomy at that time?
No, ma'am, they didn't check out the ureter. Later on again, they followed up and later, of course, excised. But first, it was a simple nephrectomy specimen for non-functional kidney.
Yeah, so if it is not a contiguous spread and it was present, if the tumor was present in the distal portion of the ureter or the mid portion of the ureter, it was not contiguous, then I would stage these as two different tumors. And that can happen, right? You can have a large pelvic ileal tumor, which is staged according to the renal pelvis staging, and then the ureteric tumor will be staged as the tumor arising in the ureter. So you want to different stages.
Yes, sir. Thank you, ma'am. Another doctor is sharing that she got to see RCC in vagina and cervix also.
They can happen anywhere. Bottom line, you just need to kind of keep it in mind that you can have tumors arising anywhere, myths arising anywhere in the body.
Ma'am, we have wrapped up all the questions, sir. Beautiful. And ma'am, we enjoyed the class very much. And Santosh Minister, thank you so much for your presence.
Thank you for the opportunity, and